Comment. Good evening, friends. Today's topic is lipoproteins and hyperlipoproteinemia. This is really important topic and conceptual topic. We will try to understand with the help of animations and few mnemonics. Lipoproteins. You all know lipids. Lipids are insoluble in water. Yes, define lipid how it is defined. That any compound which is insoluble in water, soluble in organic solvent is lipid. So blood is water based. So lipids are insoluble in blood also. So to transport lipid in our body, lipids are connected with protein to make lipoprotein. So, so lipoprotein is lipid plus proteins. If you see, they are having similar structure. Means if I say chylomicron remnant, VLDL, IDL, LDL, HDL. These are lipoproteins and all these are having common structure means they have lipid and they have protein. So if you see the structure in detail, you will find that polar component is kept in the periphery and non-polar component is kept in the center. Means lipids are insoluble in blood. To transport lipid, nature made lipoprotein means proteins are attached with lipid. Proteins are having charge. Proteins are having polarity. Due to this polarity, now lipoprotein will travel via blood very easily. So if I say triacylglycerol, triacylglycerol, it is neutral fat. Neutral fat. Cholesterol ester. Cholesterol ester, it is having no charge. So they are non-polar. They will be kept in the center. Anything which is non-polar will be kept in the center and which is polar will be kept in the periphery so that they can travel via blood. So triacylglycerol and cholesterol ester in the center. If I talk about cholesterol only, cholesterol, you can say it is amphipathic. Cholesterol, all is there. All means polarity is there. This ring, aromatic ring, non-polar. So it is having polar and non-polar component. If I place cholesterol in lipoprotein, I will place here cholesterol. And in the most periphery, there would be proteins. So the protein which is found in lipoprotein, we name them as apoproteins. Apoproteins. So it means that chylomicron, VLDL, IDL, LDL, HDL are having similar structure. In the periphery, they are having apoproteins and different types of apoproteins are there. ApoA1, ApoA2, ApoC1, ApoC2, ApoB48, ApoB100. We will discuss shortly in detail. For the time being, all these apoproteins will be present in the periphery due to the charge of these proteins, due to the polarity of these proteins. These lipoprotein will travel via blood. So lipids are transported in the form of lipoprotein. A question is asked, free fatty, yes, free fatty acid. It is not free. Yes, this is a PG entrance question. Sometimes Viva, this question is asked. Free fatty acid is present in our blood attached with albumin. Okay, so many times we feel that it should be free, but it is attached with albumin. The purpose to transport lipid, that we want to attach lipid with polarity. Now, we will see the structure of each and every lipoprotein. We will discuss the transport of these lipids and how these are metabolized, and then we will correlate with this structure and their function with hyperlipoproteinemia. We start with the chylomicron. Chylomicron is the largest. It is having maximum triglyceride. So it is largest and HDL is smallest. So you will remember this shape. So this is, you will remember that the size is decreasing. You know, fat is very light. I remember a joke. हिंदी में देख लेते हैं. एक बार एक नई नई शादी हुई बहू गई, वो मट्ठा भिगो रही थी, तो मक्खन ऊपर तैर रहा था. जब मक्खन ऊपर तैर रहा था तो बहू ने कहा, सासू माँ मक्खन तैर रहा है, कहाँ उतारूं? सासू ने कहा, बहू मक्खन लाल तेरे पिता का नाम है, थोड़ा इज्जत से लिया कर. नेक्स्ट डे वो करने लगी. फिर मक्खन आया, कहने लगे सासू माँ, बाबूजी मट्ठे पे तैर रहे हैं, कहाँ उतारूं? द पर्पज इज नॉट फॉर जोक. द पर्पज इज दैट लिपिड्स आर वेरी लाइट, देयर डेंसिटी इज लो, so they float over. Yes, in blood, if you take sample, many times you will find that this concept is useful. They float over that solution. So this is, lipid is maximum, so minimum density, least dense. Lipid is maximum. Yes, size maximum. So you can say lipid content decreases in this direction. First question. Size decreases in this direction. We have seen size decreases in direction. So we are discussing chylomicron, VLDL, VLDL remnant, LDL, HDL. In this, size is decreasing. Yes. Density will increase. You know, proteins are dense. Proteins are dense. So maximum protein. So most dense. Name itself tells you high density lipoprotein. So if question is asked about lipoprotein, you can make this and you can write in this way: lipoprotein, lipid maximum in chylomicron, minimum in HDL. Size maximum chylomicron, minimum HDL. Density least dense chylomicron, maximum density HDL. Protein least content in chylomicron, maximum content in HDL. So if you do ultracentrifugation, point it out. Many times this question has been asked in PG entrance also, and in Viva also they will try to confuse. Ultracentrifugation, if I do ultracentrifugation, you will find the lightest thing would be here. So this is chylomicron. This is chylomicron, this is VLDL, IDL, LDL, HDL. Why I am telling you with so much of stress? Because sometimes they will confuse you with electrophoretic mobility of lipoprotein. You know electrophoresis? In electrophoresis, single liner question that chylomicron, this is the point of application, this is chylomicron. Name itself tells you कम move करेगी, least movement chylomicron. This is HDL, highest movement with the HDL. So this band is called alpha. So alpha lipoprotein, other name of HDL is alpha lipoprotein. This is beta lipoprotein. This is LDL. This is VLDL. And this is called pre-beta. Point it out, pre-beta lipoprotein. And this is IDL, broad beta. Again, I am pointing out this sequence sometimes in, if this is, it is rotated vertically. So this sequence of ultracentrifugation and electrophoresis would be different. So you will remember like this, come. सबसे कम मूवमेंट काइलोमाइक्रोन, सबसे ज्यादा मूवमेंट एचडीएल. अल्फा और बीटा के बीच में दो चीजें होंगी. बिटवीन अल्फा एंड बीटा देयर वुड बी वीएलडीएल. दिस इज कॉल्ड प्री बीटा, जस्ट बिफोर द बीटा. एंड आइडियल, इट इज ब्रॉड बीटा. So you will remember this. Single liner questions, multiple questions are there. And in exam, if question is asked on lipoprotein, you will write all these things. Now, we start with chylomicron again. You took food. In our food, we have carbohydrate, we have lipid, we have protein. We know carbohydrate can be transported easily, no need of any other thing. Yes, glucose, you know blood glucose level is there. Proteins, albumin is there, globulin is there, normally transported. But lipids are transported in the form of lipoprotein. So first lipoprotein is chylomicron. We ingested food. Normally we avoid cholesterol. Definitely we avoid cholesterol. Nobody want to take cholesterol. So nature said, okay, whatever food you are eating, in that food the maximum content would be triglyceride. Some amount of cholesterol would be there. You know, cholesterol is not desirable. So we found that in our diet there is triglyceride. You ingested in intestinal mucosal cell. This is smooth endoplasmic reticulum. This triglyceride will be absorbed in the form of fatty acid and glycerol. Fatty acid and glycerol. This will join to form triacyl glycerol. This triacyl glycerol now come out of this smooth endoplasmic reticulum by MTP, or sometimes called MTTP, microsomal triglyceride transfer protein. And now in intestinal mucosal cell, there is synthesis of chylomicron. And we found that in chylomicron, there is ApoB48. So now it is primary chylomicron, nascent chylomicron, in which you will find two important aspects or two important composition. One is triacyl glycerol and second is ApoB48. So I can say chylomicrons are assembled in intestinal mucosal cell. So direct single liner question, and if question is asked, you will write down all these things. It contain ApoB48. It is important point because this is specifically present only in chylomicron. No other lipoprotein contain ApoB48. Carry dietary triglyceride to peripheral tissue. I told you that we took diet. Triglyceride came in our diet. Intestine mucosal cell. It is assembled in the form of chylomicron, and each and every lipoprotein has the same function, transport of lipid. So this chylomicron will transport dietary lipid, dietary triglyceride, definitely dietary triglyceride. It contain maximum triglyceride. We have already discussed that it contain maximum lipid, maximum triglyceride largest. This is exogenous triglyceride. This is important. You all have learned that triglyceride is synthesized in our body, and triglyceride comes in our body from diet. The triglyceride which comes from diet, that is called exogenous, which is synthesized in our body in liver, that is called endogenous. So this is coming from diet. So this chylomicron contain, yes, exogenous triglyceride. This nascent chylomicron is released in blood. Now this chylomicron was moving via blood. What was the aim of this chylomicron? To give this triglyceride to different tissue. Now, this chylomicron, I'm making a story, little bit humorous. Yes, this chylomicron met HDL, high donor, not wiki donor. It is highly donor. So HDL said, ले बच्चा, ApoC2 ले जा, ApoE ले जा, तेरे काम आएगा. Is you must have seen many, mythological. तेरे काम आएगा. So in the same way, yes, HDL gave ApoC2. Yes, ApoC2 and ApoE. So HDL said, took this ApoC2, ApoE, it will be useful for you in future. Chylomicron accepted, okay, I take. So ApoC2 and ApoE. Now this is ApoC2 and this is ApoE. Now I can say that chylomicron contain ApoB48, ApoC2 and ApoE. Now this is traveling via blood vessel. This ApoC2 will activate this lipoprotein lipase. You all are aware about this word, lipoprotein lipase, that lipoprotein lipase is present at endothelium. So this is present at endothelium. This ApoC2 activated it. Wake up. Now, this lipoprotein lipase will cut lipid. lipid is triacyl glycerol. So this triacyl glycerol will be cut and this will release fatty acid to the tissue. Yes, fatty acid will be released. And definitely is the purpose of chylomicron. Yes, we want that whatever diet we have taken, whatever triacyl acid we have taken in diet should be distributed to different cell in our body. So this is done with the help of lipoprotein lipase. And who activated lipoprotein lipase? ApoC2 activated lipoprotein lipase. Now it will cut triglyceride and release fatty acid. So as it will travel, most of the, yes, more and more of triglyceride will be released, and ultimately you will say this is the remnant part of chylomicron. ये बचा हुआ है, बाकी सब खा गई, अब जो बचा उसे कहा रेमेनेंट. Point out, this ApoC2 is released from this chylomicron, and now this chylomicron remnant contain ApoB48 and ApoE. ApoE. Question. With the help of ApoE, now this chylomicron remnant will be taken up by liver. There is a receptor at liver, and the ligand for this receptor is ApoE. This chylomicron remnant will come, and this ApoE on this chylomicron remnant will recognize this receptor and will bind, and this will be taken inside. रिसेप्टर mediated endocytosis. क्या कहते हैं इसे? Receptor mediated endocytosis, and now it is taken inside the liver and digested. So the external exogenous triglyceride, the role is over. Point it out. So we have digested the exogenous triglyceride. We can see animation for this. Okay, some technical issue is there. Anyways, कोई बात नहीं, just understand. So what happened? This chylomicron is traveling, it is activating lipoprotein lipase, and when it will activate lipoprotein lipase, this will cut triglyceride and fatty acid will be released, and this will be taken by different cells. Now it will be converted to chylomicron remnant, and chylomicron remnant will be taken by liver with the help of ApoE. Now I will point out that in our diet we took mainly triglyceride. Very small amount of cholesterol is also there. So when this chylomicron was assembled, it contained mainly triglyceride. What does it mean? Means if in any hyperlipoproteinemia or any disorder, if chylomicrons are increased, you will say triglycerides are increased, cholesterol is normal or near normal. Again, I'm repeating, in any hyperlipoproteinemia, chylomicrons increase, you will say triglyceride increase, cholesterol is normal or near normal. If I take a simple example, suppose triglyceride is 100, cholesterol is 1, you will say 1 is negligible in comparison to 100. This is just representative, just to make you understand and simplify. Now, as it will move, more and more triglyceride is released. This chylomicron remnant will contain will contain both triglyceride and cholesterol. Suppose 90 molecules of triglycerides are gone and 10 molecules of triacylglycerol left and 1 molecule of cholesterol is there. You will say in this chylomicron remnant, both triglyceride and cholesterol are there. Means in any hyperlipoproteinemia, if chylomicron remnants are increased, you will say both triacylglycerol and cholesterol increased. Clear? I know I should discuss first of all the complete lipoprotein metabolism, but I will discuss hyperlipoproteinemia type 1 at this time only. Yes. Hyperlipoproteinemia type 1 or familial hyperchylomicronemia. In type 1 hyperlipoproteinemia, there is defect in lipoprotein lipase. If lipoprotein lipase is defective, you can tell me. If lipoprotein lipase is defective, this chylomicron will not be metabolized. When this chylomicron will not be metabolized, there would be increased chylomicron in blood. That's why type 1 hyperlipoproteinemia is called familial hyperchylomicronemia. Chylomicrons are increased. And you know, chylomicrons are having mainly triglyceride. So lipoprotein increase chylomicron, and chylomicron contain mainly triglyceride. And you know, whenever triglyceride is increased, it put extra pressure on pancreas. In surgery, a frequently asked MCQ that predisposing factor for pancreatitis, hypertriglyceridemia. So triglyceride is increased in type 1 hyperlipoproteinemia. I will summarize and I will tell you how you will write answer in your prof. Don't worry, but try to correlate at this time and solve question, because MCQs are being asked in your prof exam also. So triglyceride is increased. Due to that, it will put pressure on the pancreas, pancreatitis, and you know, pancreatitis present with acute abdomen. And I told you that triglyceride is white in color, white butter. So you will remember triglyceride as butter. So if triglyceride is butter, this type 1 hyperlipoproteinemia, if I take sample, I will find milky white plasma. Question. This question has been asked 2-3 times. Milky white. What is the color of triglyceride? Yes, white. Milky white plasma. Yes. You know what is the plasma. Now, what is the color of blood? Blood is also having red blood cell. Red blood cell means red color. Blood is having red color. And this triglyceride is having white color. You know, soup, cream of tomato soup, red color, and the cream, white color. So when chylomicronemia is there, the appearance of blood would be cream of tomato soup, appearance. One question was asked, you take sample of hyperchylomicronemia, familial hyperchylomicronemia, you kept the sample at 4 degrees centigrade overnight. And there was supernatant milky white layer. You know, triglyceride is very light, very low density. If you will keep it overnight, it will float over it. So supernatant layer, this question was asked. So milky white plasma, cream of tomato soup appearance, supernatant layer, white layer. Got the point? Now, if I remember that butter is triglyceride, it may be white or it may be yellow. Okay, so if triglyceride is increased, chylomicrons are increased. Normally, if you do fundoscopy, there would be pinkish hue. But in this hyperchylomicronemia, blood vessel is having chylomicron. So lipid is increased. So this appearance would be there. This is called lipemia retinalis. Okay, whitish hue would be there, not pinkish, whitish. And you have learned, I'm trying to make mnemonic. Your parents must have told you that if ghee is granular, that is good ghee or good butter. So butter is usually granular if the real butter you have seen. So if triglycerides are increased, chylomicrons are increased, there would be deposition of this butter. Yes, yeah, this is eruptive xanthoma. This is eruptive, nothing. Actually, this is not the exact pathophysiology, but you will remember in your exam. Yes, eruptive xanthoma. Yes, this is yellowish discrete papules. Yes, yellowish discrete papules, eruptive xanthoma, granular appearance. So this is type 1 hyperlipoproteinemia. I told you, and I told you in this chylomicrons are increased, and this is not complete till now. In this, acute abdomen would be there, triglyceride will be increased, and all these features I have discussed. But I told you that lipoprotein lipase is activated by ApoC2. So if ApoC2 is defective, then lipoprotein lipase will not be activated. Actually, what happened? Few patients were there in which there was hyperlipoproteinemia type 1. When we analyzed, we found that lipoprotein lipase defect was not there. We found that in these patients, the defect was ApoC2. When ApoC2 was not there or was defective, then lipoprotein lipase will not be activated, and the feature would be just like type 1 hyperlipoproteinemia or familial hyperchylomicronemia. So defect may be either this or this. Clear? Now, so type 1, I have little bit left, but most of the component is covered. So I told you, you eat food, blood glucose, sorry, you eat food, triglyceride came intestine chylomicron formed, chylomicron released in blood, it travel via blood, triglyceride given to different cells. Now it will come to chylomicron remnant is taken by liver with the help of ApoE. Now this exogenous triglyceride acts. You know that in our body, extra carbohydrate is converted to fat. Yes, we know carbohydrate diet we take. Carbohydrate, you know, 60-70% of our diet is carbohydrate. And this carbohydrate is used for energy production, around 50%. 50% is around stored. 50% about stored. Out of 50%, 10% is stored in the form of glycogen and 40% in the form of triacylglycerol. Means in our body, carbohydrate is converted to triacylglycerol fat. This is the reason that if you want to decrease weight, decrease carbohydrate in your diet. Question was asked, Atkins diet. Atkins diet is low calorie plus low carbohydrate diet. We tried a lot. हम कब से वेट कम करना चाह रहे हैं? What we do? We stop घी, तेल सब बंद कर दिया एंड ब्रेक हुआ, ब्रेक में चिप्स ठूस लिए. अब जब चिप्स ठूसोगे तो चिप्स में क्या है यार? कोलेस्ट्रॉल. क्या है? कोलेस्ट्रॉल. एंड सॉरी, चिप्स में क्या है? वो तो लिख देते हैं उसमें, सॉरी. चिप्स में है यस कार्बोहाइड्रेट, और एक्स्ट्रा कार्बोहाइड्रेट कन्वर्टेड टू triacylglycerol. This triacylglycerol is endogenous. Exogenous or endogenous? This is endogenous. So liver synthesize endogenous triglyceride. Now liver want to transport this triglyceride to peripheral tissue. Now liver will make a lipoprotein. You know triglyceride cannot be transported as such. To transport liver synthesized triglyceride and sorry, liver synthesize a lipoprotein that is called VLDL. So question is asked on VLDL, direct question. And if question is asked in your prof exam about VLDL, these are produced in liver, has maximum endogenous triglyceride. Yes, chylomicron was having exogenous. This is having endogenous. This carry endogenous triglyceride from liver to peripheral tissue. Definitely each and every lipoprotein is having common function to transport lipid from one place to another. So when we saw the structure of VLDL, we found that VLDL contain ApoB100. And in the center, it is containing triacylglycerol. Same, just like chylomicron. But chylomicron ApoB48, in this ApoB100. Now this VLDL will travel via blood. When VLDL will travel via blood, it will encounter HDL, highly donor, not wiki donor, highly donor said, yes, you may take ApoC2 and ApoE from me if you require. As VLDL said, okay, I accept. So again, ApoC2, ApoE came to it. Now, when it was traveling via blood vessel, this ApoC2 again activate lipoprotein lipase. It activate this lipoprotein lipase. Lipoprotein lipase will remove triacylglycerol and fatty acid will be released. After traveling a certain distance, a particular amount of triglyceride is released. The remaining amount, yes, the remaining amount containing both triglyceride and cholesterol. Same concept. We found that VLDL contain mainly triacylglycerol, very small amount of cholesterol. But when most of the triglyceride is removed, now only few molecules of triglyceride left and few molecules of cholesterol left. Now we can't say that cholesterol is negligible. So we will make a mnemonic here to solve multiple questions here. Chylomicron, VLDL. Chylomicron, remnant, VLDL, remnant. The name is ideal. Okay. So we found that chylomicron, VLDL contain only and only triglyceride, one word, one type of lipid. Two words, two words, two types of lipid means both triglyceride plus cholesterol. So in any hyperlipoproteinemia, if remnants are increased, again I am repeating, in any hyperlipoproteinemia, if remnants are increased, you will say both triglyceride and cholesterol increased. In any hyperlipoproteinemia, if chylomicron on VLDL increase, you will say triglyceride increase. So I come to type 1 hyperlipoproteinemia again. Yes, if lipoprotein lipase is defective, or ApoC2 is defective, then VLDL will not be metabolized. So in type 1 hyperlipoproteinemia, yes, chylomicron increases and also VLDL increases, but chylomicron increases more than VLDL. Okay. And both contain mainly triglyceride. Triglyceride increase acute abdomen, pancreatitis. Yes. Milky white plasma, lipemia retinalis, eruptive xanthoma. Again, we come to our metabolism. Again, I am repeating, in the last, I will summarize how to write in your exam when question is asked on this lipoprotein and hyperlipoproteinemia, how you will answer your question. Don't worry. I will take care of that. So ideal or VLDL remnant. Now VLDL remnant or ideal contain ApoB100 and ApoE. ApoC2 is lost. Now this ideal has two options. Ideal has two options. Either it will go to liver. You all know liver is having receptor for ApoE. Yes, I told you liver has receptor for ApoE. So it has two options. Either it will go to liver and will be metabolized, or it will move further and all the triglyceride removed, all triglyceride removed. Yes, all triglyceride removed. And ApoE is removed. ApoE is removed. The remaining part is called LDL. So अब ये बन गया LDL. So you will remember the sequence. VLDL is converted to ideal. Ideal is converted to LDL. Question is asked. LDL is containing only two things. One is ApoB100 and other it contain cholesterol. And this cholesterol is good cholesterol or bad cholesterol? Bad cholesterol. Now this LDL is further metabolized by liver. Liver will take this LDL, or this LDL will deposit its cholesterol to peripheral tissue. You all are aware, questions are asked on LDL multiple times, that LDL is containing bad cholesterol, why it is called bad cholesterol, and how it produces atherosclerosis, cardiovascular disease, myocardial infarction. Yes, you know LDL is having cholesterol. The fate of LDL, most of the LDL is taken up by liver with the help of LDL receptor. Some amount of LDL go to peripheral tissue and deposit cholesterol over there. So in liver, there is no need to worry, because you know cholesterol can be converted to bile acid and this bile acid can be excreted. But in peripheral tissue, bile acid cannot be synthesized. So in peripheral tissue, it will remain deposited and it will be oxidized, then atherosclerosis, cardiovascular disease. Got the point? So this LDL is having bad cholesterol. It will deposit this cholesterol in peripheral tissue and will predispose to atherosclerosis. Now, or cardiovascular disease. Questions are rotated over this. This is very, very important. If questions are asked on lipoprotein, yes, LDL metabolism must be discussed in detail, and separate short note on LDL and its metabolism is frequently asked. Now, we found that this is LDL receptor and this is LDL receptor adapter protein. Yes, this is LDL receptor adapter protein. We suppose my hand is LDL receptor and this is ApoB100, and ApoB100 comes, or you can say the complete my hand is LDL having ApoB100. Now this LDL receptor will recognize this ApoB100 and will bind it, and will take this LDL receptor mediated endocytosis. So in this means from blood, LDL is taken inside the liver with the help of ApoB100. ApoB100 should be there. LDL receptor should be there. LDL receptor adapter protein should be there. If any one of these three is defective, LDL will not be taken from blood, and this LDL will deposit cholesterol in peripheral tissue. So there would be increased chance of cardiovascular disease. Got the point? So now I discussed type 2 hyperlipoproteinemia. Type 2 hyperlipoproteinemia. In type 2 hyperlipoproteinemia, defect in ApoB100, ApoB100 defective, or LDL receptor defective, or LDL receptor adapter protein is defective. So in any case, there would be no metabolism or taken up by liver of LDL. So LDL will increase in blood. LDL increase in blood. And LDL contain, yes, only and only cholesterol. So cholesterol increases. And you know, whenever cholesterol is increased, cholesterol predisposed to, yes, cardiovascular disease, or yes, myocardial infarction, chest pain. Point it out. Type 1 presented with pain abdomen. Type 2 presented with chest pain. Abdomen एक है, पेन एब्डोमन, चेस्ट दो है, दो साइड लंग. ओके, ऐसे याद रख लो यार, है ना. हार्ट तो एक ही होता है हमारा, बट चेस्ट पेन. Yes, we found that whenever this cholesterol is increased, this cholesterol, I remember just like egg yolk. Cholesterol is egg yolk, and if this deposit here, yes, type 1A नहीं, type 2A होता है ये. Yes, type 2A. If you want to be more precise, type 2A. फ्रेडरिकन क्लासिफिकेशन अभी हम डिस्कस करेंगे, उसमें टाइप 2A होता है. यदि तुम्हें प्रिसाइज होना है तो कोई बात नहीं. कोलेस्ट्रोल is deposited here. So this is again mnemonic. When cholesterol increase, that is tendon xanthoma. Tendon xanthoma. Yes, and most common site is tendo Achilles. Yes. So we found that any of this defect, ApoB100 defect, LDL receptor defect, LDL receptor adapter protein defect, may lead to this type 2 hyperlipoproteinemia. In this, cholesterol is increased. That's why it is called familial hypercholesterolemia. Now, एक क्वेश्चन देखते हैं. You can answer this very easily. A 7-year-old boy presented with severe abdominal pain abdomen. On examination, he had, yes, xanthoma, usually eruptive xanthoma. If you want to precise, yes, eruptive xanthoma. Blood sample taken for workup. Blood sample had milky appearance of plasma. Which of the following lipoprotein is increased? Milky white plasma, chylomicron. Yes, chylomicrons are increased. Now, second question, on laboratory investigation in patient, LDL was highly elevated, but the LDL receptors were normal. LDL receptor normal, but LDL is elevated. So if LDL receptor is normal, there may be defect on ApoB100, there may be defect on LDL receptor adapter protein. So yes, which of the most probable cause? This may be due to ApoB100 mutation. If LDL receptor is normal, there may be defect in ApoB100. Now, one aspect which was left, I will discuss that part. Yes, PCSK9. PCSK9. What is the function of this PCSK9? This PCSK9 take this LDL receptor and put this LDL receptor to lysosome. Som, som, samo, sha, sa, sha. You must have seen many Hindi movies in which villain do like this, and he has a acid pool, and that is lysosome, acidic pH. So anything go to that pool is digested. So this PCSK9 took this LDL receptor unit and put into lysosome. It is destroyed. Okay. So if there is mutation, or simply it is working extra, if it is extra working, so means it will degrade more and more LDL receptor. So mutation in PCSK9 is gain of function mutation. You all know that whenever usually mutation occur, the function of protein is decreased or lost. But there are few mutation in our body in which protein function is increased, that is called gain of function mutation. So if this mutation occur in PCSK9, we found that it is gain of function mutation. Now the function of PCSK9 is increased. Now more and more this yes, LDL receptor is degraded. When LDL receptor is degraded, this LDL will not be taken by liver. LDL will, yes, deposit cholesterol in peripheral tissue and myocardial infarction. So now, what concept is there? I will tell you the true story. In South Africa, there was a population. In South Africa, there was a population. There was low incidence in this population of myocardial infarction. When we analyzed that they are having low PCSK activity, it means low PCSK activity was there. When low PCSK activity was there, these receptors were not destroyed. These receptors are more at liver, more receptor, more LDL will be taken by the liver. So in blood, LDL would be decreased. So decreased chance of myocardial infarction. So we started thinking, if we make antibody against this PCSK9 and we destroy this PCSK9, then we can avoid myocardial infarction. That's why, yes, we have evolocumab, alirocumab monoclonal antibody, which is against PCSK9. Question, recently asked question in INI. So now you understood what is the significance of this PCSK9. So if question is asked, you must discuss about this PCSK9 and highlight it in your theory question also. Yes, and you can also put the story, what I have told you. So till now we have discussed type 1 hyperlipoproteinemia, type 2A hyperlipoproteinemia, that is Fredrickson classification of hyperlipoproteinemia. Hyperlipoproteinemia may be broadly divided into, if only and only triglyceride increased, then type 1, type 4, and type 5. Fredrickson classification type 1, 4, and 5. Yes, this classification is not commonly used nowadays, but is present. So in Harrison, you will find a different table. But in your exam, you can make this flow chart like this. So type 1, 4, and 5, triglyceride is increased. Type 2 or type 2A, type 2A, only cholesterol is increased. And type 3, both triglyceride and cholesterol increased. Now you will remember by mnemonic. Yes, type 3 looks like E. Whenever I look at 3, it looks like E. So in type 3 hyperlipoproteinemia, ApoE is defective. ApoE is defective. If ApoE is defective, you all know that remnants, yes, chylomicron remnant is taken up by liver with the help of ApoE. VLDL remnant or ideal is taken up by liver with the help of ApoE. So if ApoE is defective, then remnant will not be taken up by liver. So when this is defective, remnants are increased. Remnants are very good. Correct answer you have given, I think. Which question? Sorry, I could not see your message. Yes, remnants are increased, and I told you remnants contain both triglyceride and cholesterol. Both triglyceride and cholesterol increased, and when both triglyceride and cholesterol increased, there would be, yes, tuberoeruptive xanthoma. Yes, let me tell you, cholesterol increased, sorry, cholesterol increased, tuberous xanthoma, triglyceride increase, eruptive xanthoma. So tuberoeruptive xanthoma. So type 3, I write here. Type 3 hyperlipoproteinemia. Defect is ApoE is defective. When ApoE is defective, remnants are increased. Remnants are increased. These remnants are VLDL remnant and chylomicron remnant. And remnant contain both cholesterol and triglyceride, so both are increased. Whenever cholesterol increases, I told you cholesterol increase, tuberous xanthoma or tendon xanthoma. Whenever triglyceride increase, eruptive xanthoma. So you can say both triglyceride and cholesterol increase, so tuberoeruptive xanthoma. Tuberoeruptive xanthoma and palmar xanthoma means there would be crease, yellowish deposition at the crease, that is palmagenthoma, and bunch of grape appearance. Yes, grapes like appearance, small, small, big, small, small. This is a grape of, yes, bunch of grape appearance, and this is palmagenthoma. And we found that, yes, a third, this question, answer, please give me answer. Yes, 30-year-old male patient came to medicine OPD for swelling, which looked like grapes. He said initially it was small cluster of swelling, which later increased in size. He also complained of yellowish pigmentation of crease of palm, palmagenthoma. Fasting lipid profile was done. Both cholesterol and triglyceride increased. So this is type 3 hyperlipoproteinemia. Type 3 hyperlipoproteinemia, another name is dysbeta lipoproteinemia. Type 3, another name is dysbeta lipoproteinemia. Clear? So this is about. So in this answer is yes. Now please tell answer. Very good. Answer is D. Familial dysbeta lipoproteinemia. Okay. So these are common hyperlipoproteinemia and lipoprotein metabolism. HDL is left. We will discuss HDL in the next session. And HDL and hypolipoproteinemia we can discuss in the next session. Just to summarize, yes, what we have learned, if long question is asked, how you will write? First of all, you will write the structure of lipoprotein, then you will can tell the property of lipoproteins and their size, density, protein. Then make this ultracentrifugation. It is very simple to make ultracentrifugation diagram because you know the sequence. How you will remember the sequence? Yes, I told you that chylomicron. Yes, the purpose to give you this is chylomicron, chylomicron remnant, VLDL, IDL, LDL, and the last one is HDL. So sequence you will remember very easily. Ultracentrifugation. This electrophoretic mobility, काइलोमाइक्रोन कम मूवमेंट करेगा, HDL हाईएस्ट मूवमेंट करेगा, इट इज ऑल्सो कोल्ड अल्फा लाइपोप्रोटीन, LDL इज ऑल्सो कोल्ड बीटा लाइपोप्रोटीन। इससे जो पहला होगा वो प्री बीटा, VLDL को प्री बीटा भी कहते हैं, आइडियल ब्रॉड बीटा। ओके, इसके बाद तुम काइलोमाइक्रोन से शुरू करोगे। यस, यू विल डिस्कस ऑल द पॉइंट्स ऑफ काइलोमाइक्रोन, हाउ इट इज सिंथेसाइज्ड एंड व्हाट इज द सिग्निफिकेंस ऑफ दिस microsomal triglyceride transfer protein to synthesize this. And in this way, chylomicron, then its metabolism, how these nascent chylomicron is converted to mature chylomicron, ApoC to ApoE what is the function of ApoC2, what is the function of ApoE, and then how it is ultimately taken by liver with the help of receptor mediated endocytosis. Then VLDL, how it is synthesized, you can discuss this. Carbohydrate can be converted to fat, that is endogenous triglyceride, which is transported in the form of VLDL. Again, the importance of HDL, highly donor will donate ApoC2 and E, and then when it travel again, this function of lipoprotein lipase, this ideal fate, ideal, when you will discuss ideal, you will discuss that ideal can be taken by liver, further metabolized and converted to LDL. And in LDL, you will discuss each and every point about LDL receptor adapter protein, and ligand for LDL receptor is ApoB100 and this PCSK9. And at the same time, PCSK9, when you will write, yes, you will write evolocumab and alirocumab, it will give extra S. So this is about hyperlipoproteinemia. And in the last but not least, yes, prediction classification, you can write like this and you can make this table. Thank you for patience listening. Best wishes for your exam. Remain connected. We will come with more and more sessions so that you can boost your preparation for your upcoming prof exam. So remain connected. Thank you.